Good morning, this is Dr. John Bennett broadcasting from Miami Beach, home of Neurosurgical TV. I'm honored with the presence of Cyprian Ionita. He's a PhD from the University of Buffalo. I initially had a webcast with Cyprian a few years back with 3D printing in neurosurgery, and learned that they're closely associated with the Jacobs Medical School and University of Buffalo, and Cyprian, I'm sure, will talk about that. And we'd like to welcome Cyprian, and thank you. It's all yours.
Thank you very much. Thank you for the introduction. I will present today a first lecture of a series of 3 into artificial intelligence. And full disclosure, the entire work that I'm presenting today, it is actually the work of my PhD students. I'll present it in this lectures. So my idea is to do a kind of like a very high level kind of a presentation on the AI with followed by direct applications to neurosurgery. And the lectures are organized in such a way that we go from things that are easily acceptable in the clinics and in the neurosurgery, and then increasingly growing into complexity and impact. This lecture today on the AI will be mostly focused on the fact that, listen, the message is, look, AI can replicate what humans do in the diagnosis and stroke, as well as a highly trained neurosurgeon. And the advantage that is to this application is that it does it in about 6 milliseconds to about 10 milliseconds, let's say, per case. It can go through an entire CT scan, and right away the results are presented to you. So in that context, today I will focus on stroke and the kind of like severity and identification of the patients. And full disclosure, this work has been funded by different federal institutions like NIH and National Science Foundation. And we also have, we're working towards a small startup, CAS AI at the University of Buffalo. So really quickly, we've seen the AI and the machine learning, all the buzzwords that are everywhere nowadays. We heard it from self-driving car, facial and speech recognition, and general and game playing. But I don't think in the medical realm has been yet such a big turnaround or such a big acceptance, mostly because of the really deep implications that it have on personal level or on patient health, and also regulatory kind of organizations where we need to make sure that what we're doing, it is right. So what can we do like in the medical applications? And we've seen it over and over again. Radiology Society of North America has dedicated an entire journal where the AI is used for segmentation, really identify regions and segment them out, which means isolate them and extract features. Why is that? Well, because it is mostly because of time savings. Segmentation for a radiologist can take minutes, dozens of minutes, up to hours if they have like a very difficult structure in their images. So other things is that it can look at different patterns into anything like a tumor or or hemorrhages and so far, and then based on existing data sets, it can actually uh, identify disease severity and can come up even with device suggestions, lesion significance. And this is what the next two presentations are going to be focusing on. Today, I will really just focus on mostly on the first part of it, time savings and identifications of stroke lesions in order to streamline the work into the hospital. So what is a machine learning in itself? Is actually we identify a mathematical model that that does a transformation, like A goes into B. For example, you show a bunch of fruits and you teach them, hey, this is an apple and this is a pear, or and so far and so on. So it is really, we teach the machine a mathematical function that does that kind of a transformation. So how is it done? Well, we have an input, in this case, a database. We have a database of images, and we assume that there is some sort of transformations that takes it to an output. We have a whole bunch of CT scans that some have hemorrhage, some are not, and we have to say, yes, there is a hemorrhage or not, for example. And then we compare with a ground truth label. This is where the expert users are located. Without the expert users, without the radiologists, without the neurosurgeons, all this cannot be accomplished. So the having medical staff, the neurosurgeons, having the cardiologists, and all the folks into the clinical setting that makes this decision, it is extremely important. Without them, actually, none of this will be possible. And what we do, we compare this whatever machine tells us with the ground truth, and if we don't like it, we go and we readjust this function, and we can go this thousands, 10,000 times and so far, and it can go for uh, days in training until we find the proper transformations that takes this point into an output that agrees with the clinical exam, with a clinical labeling, let's put it that way. Really, here as an example, you take an image and you have all these outputs. To know is that for these outputs, you really have to, they're preset. In other words, we need to talk with the physicians and with the radiologists to actually identify these labels. The machine, once it's trained, will not be able to go outside these labels in order to identify a disease that is not has not been taught to recognize. And what it does, it calculates probabilities that it tells that, hey, based on my first iteration, the probability that this is a cat is very high. Obviously, we compare this with the normal things and with the normal labels. In this case, the prediction it says that is a cat, which is untrue. The ground truth is dog. Then we go back and readjust this function until we have a really good um, prediction of this label. And as it goes at it, you see like this predictions, these probabilities that this particular image is a dog is increasing while the other ones are decreasing. And we keep going at it until through this iteration process, until the error, it is a lot less between the prediction and the actual labels. So we are looking for this function to get better and better. And finally, after many iterations, thousands and so far, the algorithm will do this kind of predictions. To note is that the algorithm is not never going to say this is a dog with a 100% accuracy. It's going to give you predictions or probabilities based on the labels that you have in there. And if we go to a medical space and we say, hey, is this a intracranial hemorrhage, is a ventricular hemorrhage, or a subarachnoid hemorrhage, is going to give you those probabilities that that particular presentation, it is one of those factors. So finally, when we get the algorithm to say, hey, this is a dog, and the prediction and the ground truth agree, we kind of like minimize this error and we stop the training. And now we have a machine that every time we present something to it will be able to predict this kind of a label with a high accuracy. So this procedure is done over all data. Usually for this kind of trainings, you need thousands, not maybe tens of thousands of images, which is extremely difficult in the medical world. It's not as easy as a dog that you can go online and download millions of pictures. But only by going through this approach, the method, the model becomes generalizable, and you can use examples outside of the data set that you have. So another thing that about the AI and the classification of the objects. Let's suppose we don't have that. We have, in this case, patient information about hypertension or things like blood pressure and so forth. There are the AI. What it does is actually separating these data sets. And in this case, you kind of like see there is a clear separation, or other are a little bit more complex. What the AI does, it actually calculates this very fine line in here to separate very like complex data structures or things that are not quite that obvious. And one key factor is the following, that if you have data sets where you label them versus, let's say, a disease, or you're trying to say this patient has a tumor or not, or so, if you do not see these trends with a naked eye, you look at the data and you don't see the trends, it's very unlikely that the AI will be able to do a good separation at it. So kind of an advice is that every time we use parameters to characterize a disease, let's say pressure drop, pressure gradients, or velocities across an intracranial stenosis and so far, with a NOVA or so, if we plot that data and we do not see them separating, it is very unlikely that the AI is going to have like a magic kind of a point and immediately is going to separate the patients with the disease versus ones without. So in that uh, um, kind of a idea, let's dive into the neurosurgery application. So how do we do this training and so far? We actually go through thousands and thousands of patients. We look at the angiograms, and we know precisely who has what kind of a disease. We know precisely what is the outcome. These are patients with multiple imaging techniques and very detailed outcomes at 3 months, 6 months, 1 year, and so far. Then we have uh, experts, in this case, neurosurgery fellows or neurosurgery residents, that can go through any of these data and identify every single aspects into the image. They can say, hey, there is an aneurysm right there and an aneurysm here. And then what we do, we are kind of like taking these data sets, in this case, an angiogram, and we are compare it with what the fellows or the neurosurgeons have done. Neurosurgeon more it's a less we can compare notes with them when we are in doubt, but most of the things that you see over here are actually the work of the fellows, residents, and trained people. So when we take these data sets, we train them, and we create this function that does a transformation from an image like this to something like that. And you say, well, what is the point of this? I mean, I know an aneurysm, how it looks like. Well, the thing is, if you will have someone, let's say, go and try to get the data set and outline an aneurysm, and then take some measurements from them. I don't know, like how much could the contrast took to flow through, or what is the size of this aneurysm, what is the dome size, and so it might take a couple of minutes for them to bring up the data set and then do all these measurements. Really, the AI to go from something like this to something like that, it is fractions of the second once the model is trained, which brings a lot of improvement in the workflow of the people who use it. So as of now, for AI medical applications, at least the ones that we're working, what we're trying to do, we're in the phase where we're demonstrating equivalence to human performance. Uh, the organization like Food and Drug Administration or any kind of other ones in Europe will not accept any AI unless we kind of like show that they are equivalent. And I think the field it is in this phase in here. And what we want to use it is to optimize the workflow. We want faster diagnosis. We want treatment planning. A lot of the folks now are asking us, well, give me the best place to drill a hole so I can place the clip over an aneurysm neck from the first shot. Others are asking, well, tell me how to get this deep brain stimulation uh, um, uh, pathway in such a way that I spare very difficult areas. Um, Others are asking for patient triaging. Uh, some neurosurgeons are asking us, well, tell me the hopeless cases so I don't spend time on those. I need to kind of know if a person that comes with it's worth actually reserving the surgery room and go for it or not. Others are asking, tell me what device to use. Tell me the sizes. How many coils am I going to use? What type of coil? So I go from the first shot and be done. And finally, complication detections, things that are subtle that you cannot see, like placing a stent over a branch, and you don't think that is going to occlude later, and like a pipeline, and then weeks later you figure out that the ophthalmic artery is gone, for example. So today, as far as concerning stroke, I'm going to focus on these four aspects. I'm going to demonstrate equivalence in human performance, optimize the workflow. I'm going to show you that it does faster diagnosis and how it can be used for patient triaging. So it is now standard for our neurosurgery department to have a protocol like this in here. As soon as the patient hits um, the emergency room, the first stop, it is actually the CT scanner, not the MR, not the angio room. They go to the CT scanner, and there is a four-step protocol. First of all, there is a non-contrast CT that is looking for hemorrhage, followed by a large occlusion. Once this is ruled out, we go through a second part where is large vessel occlusion, and this is an angiogram, is a CTA. While this happens, the non-contrast CT it's used for aspect scoring if hemorrhage is not been detected. And this is an Alberta scoring system where we are looking for an aspect score below the 6 hours to determine whether a patient it is eligible for thrombectomy or not. And after the scoring, it goes through the CT perfusion, and the CT perfusion based on the diffuse clinical trial, and a lot of people are using now rapid AI, Visa AI to do this. We're looking at the how much of the what is the ratio of the infarct core to the penumbra, which penumbra is for tissue a risk for infarct. So based on this ratio in here, we decide whether a patient is going to go for the thrombectomy. So in general, for mechanical, now the mechanical thrombectomy in our, at least at our center, has become one of the most used um, uh, methods for these patients. And during this procedure, a catheter is placed, and a device such as a clot retriever is deployed over the actual lesion, and the entire system is pulled out, removing the clot. Uh, there are quite their American Heart Association has very thorough guidelines about people and on how to use the imaging in order to determine eligible patients. And right now, what we're trying to do is to optimize this workflow to be from whatever it takes now. When the patient hits the emergency room, it can take up to half an hour to an hour for to get to the thrombectomy. So what we're trying right now is to use the AI to optimize this kind of a workflow. And I will go with development on the AI for ICH algorithm. One of the applications for the AI, it is to identify the hemorrhage. Why is that? Well, it's mostly convenience workflow, and it is kind of a trivial radiological task if you think about it. Most of the residents, even the fellows that are in other departments, not necessarily neurology, are, are should be able to recognize patterns like this. Why do we do it? Is because that's how we start with all these technologies. We start with things that are kind of safe. We demonstrate equivalence, and then we increase in complexity. So right now, let's say, what is the accuracy of an AI application? It's about 96% accuracy. It has 97 sensitivity. It can go through on a normal computer. It can go through an entire stack of 320 or 512 slices, and identifies whether there is an ICH or not. Um, Not only that, the we can train this if we have enough data. We can train the AIs not only to say, "Hey, there is a hemorrhage," but we can actually uh, have it, classify them. Well, it's an intraparenchymal, is a subdural, it's an intraventricular, or is a subarachnoid hemorrhage. So a lot of the AI applications, like right now and recently at the Radiology Society of North America, there was a challenge about 2 years ago in identifying this kind of intracranial hemorrhages. And the person that it was a young gentleman from Japan that developed a software was able to detect this kind of uh, hemorrhages with a accuracy of 96% or and even above. So now this is a medical product. So we heard about Rapid AI. They have a application which is both an Viz AI, and both of them are mobile applications, which means the patients get this scan. It tries to identify whether there is a hemorrhage or not, and then it blasts it to the entire staff uh, of neurosurgery and neurology. Immediately, the doctors, if they are in elevator or walking in the hospital, they get a notification on their phone. They go, open their phones, and they see the image. And then it allows them, further than that, to actually go and communicate with their colleagues to about the next steps into this procedure. And again, this is just convenience and workflow. Within probably a couple of minutes, the entire staff is notified. They can see the attending can get the results, looks at it, and gets his team going to actually with regard to the next step and to the treatment of this patient. Well, let's go through a kind of like one-on-one how is we do this. This is how my team has done the same kind of thing for intracranial hemorrhages. So in this case, we just determined the purpose is clear. Determine patients with hemorrhage. with a non-contrast CT. Then what we did, we went and asked our fellows to identify 200 intracranial hemorrhage patients. We took every single slice and we went through every single one of them and labeled it. We have about 6,500 slices and say, this is positive, this is negative. We did it for different combinations of slice thicknesses in 2.5, 3 millimeters, 5 millimeters, and so far to accommodate different kind of acquisitions. Because this kind of, I apologize, what I did not say in here, these platforms can be deployed not only at this central hospital, it can be deployed to other hospitals into the regions that do not have a um, neurology or neurosurgery staff in the hospital. And as soon as their CT scanners detect, they perform the CT scanner and upload these images, the center, the main center, in this case, a comprehensive stroke center, which is at Buffalo University, immediately gets notifications. There is like 12 to 14 hospitals which are connected into a system like this and can upload these cases. Going back to this example, then we kind of like the network, again, it is trained on this kind of slices, and these are typical slices that we have that we upload into the network or into the AI, and the output is very simple. We call this attributes. Is there a hemorrhage or is not? And then what we do is, obviously, in order to improve the AI performance, we'd have to do sometimes some imaging processing. And the key is that things like bones and other structures and calcifications and so far, they can throw off your AI. So at the end of the day, AI is just looking at the numbers and tries to figure out what's going on and there, and where these numbers are distributed, what is their intensities, and the simpler you make the problem for the algorithm, the better it becomes. And in this case, we do segmentations to throw away the bones and other things like that. And when you look at an AI, you are going to see something like this. They're going to say, first of all, well, what am I going to do with this? Well, most of the AIs cannot deal with full images data. There is a downsampling in there. 256 by 256 is actually quite big. There's others that go to shrinking the images to 64 by 64. And then the data is tested, is split. And what we do, we take 60 to train, 10, 10 to validate, and 30 in here, it is you don't show that data ever to the AI algorithm. And this is key. No kind of like a journal or regulatory organization will accept you testing your data on the same one that you use for training. And these are kind of like details of what's going on in here. But what technically is going at this level, we're taking every single image and we do some mathematical operations. And these mathematical operations are optimized in order to give you this output prediction in here. And this is kind of like the general output of an AI. And I'll go a little bit into more detail. Now, but here MCCV stands for Monte Carlo Cross Validation, which means that we look at this data and we split it in different configurations, because you cannot risk at some point that you train your AI on a biased kind of data. You randomly split this data in order to make sure that your AI performs good regardless of the splits that you have. So we do in general 20, other people do less, other people do a lot more. But at the end of the day, it gives you this plus minuses that you have in here. The question is how good it is the AI in actually identifying a hemorrhagic stroke. And when you look at the probability for accurate diagnosis, it's about 96. And we do all calculations, F1 score, sensitivity, specificity, positive predictive value, negative predictive values, the accuracy of the actual um, the accuracy of the actual algorithm, Matthew correlation coefficients, and the area under the curve. So we kind of like go, and this is kind of standard for every single one that we do, for every single evaluation that we do. The training time, pretty bad, if you ask. It's about 18 hours. But in the prediction time, not per case, per slice, it's 6 milliseconds. So once you train your algorithm, it's just go through these batches of images in really enlightening mode. So here are some examples. It's not always great at predicting. Here is a um, successful one. There is a negative one, and again failed in here. Um, Here it was a stroke positive, and here is a stroke negative, where it fails for both of them. So the next thing that we want to do, it is break down the AI. And going back to this example where we try to predict what's happening to the AI when we present an image like this, it is to look inside the AI and see how it does a decision. And this is what is referred a class activation map. So in other words, as I said, we break open the map and we create this we create this heat map showing where in the image network is drawing the classification from. So if we break down the AI, we get things like this. And what it does, it tells us that into the decision to classify this object as a dog, it uses a lot of information from these areas. In other words, this area, it is highly counted towards a decision of the network. And then what we did, we went back and broke down the AI, and we looked at it and see where was the actual pixels that counted into making this decision. Because what if, let's say, our data was biased, our CT scanner was somehow broken, and adds something into an area of the bone or an artifact or image artifact, and the AI somehow is being trained on that artifact to determine whether there is a hemorrhage or not. And what we do, we break down the AI and it puts out these probabilities. And using these probabilities, it actually decides whether a hemorrhage is present or not. And then we take these probabilities, we overlay over the actual CT scanner and say, yeah, it looks like this AI is looking at the features that matter and makes the right decision. And without this, it's really um, very, very difficult um, to accept the results of a such algorithm. So it is now almost a requirement for different journals, like AI in radiology or so far, for the users or the scientists that perform this kind of studies to provide interpretation of the AI decisions. And here is another example where it's a different kind um, of hemorrhages. And again, it accounted fairly accurate where the where the hemorrhage is, and it shows display of probabilities in order to make that decision. The next thing that we want to do, it is actually an AI hemorrhagic stroke segmentation. In other words, find out what is the hematoma expansion. And we did the same kind of things. We went through the 200 confirmed intracranial hemorrhage cases in non-contrast CT. But this time, instead of like saying, hey, there is or there is not a hemorrhage, an expert user went and by hand, and semi-automated actually, first use a threshold, identifies the location of the ICH and kind of like had to draw this kind of maps. This is a different kind of a problem. In this case, we're taking an image like this and we're trying to do a kind of labeling. most of the people in the medical field knows what segmentation is. Pretty much is find out what is within that image, and that is done again, and even before, even for the AI before, is done using what is referred as a convolutional neural networks. So what do? We take like this kind of a square, we slide it over the entire images, and this filter in here, it is what we calculate, what do we optimize. Technically, what it does, it takes this, multiplies it with that, and replaces it. It replaces one value with what was the result of this mathematical operation. And the AI, what it does, it actually calculates every single one of these parameters in the process. And then what it does also, it does something like cold pooling. What it means, it shrinks the image. You just take, like, for example, these pixels you see in here, and you just simply you can go and you look at max pooling. You're looking at the maximum value in here, and you replace and you create a smaller image, and as even a smaller. There's different ways. It's a max pooling, average pooling. That's less important. And when you do this, you go through. You've heard probably of the UNet. This is what the unit does. You take the image, you do those mathematical operations, and you make a smaller image, and a smaller image, and a smaller image. You get at this point where you do like kind of the encode or detect features into the image, and then you go back up onto this, and you reconstruct the image with the information or the labeling that you have at this point. And you recreate the image. In this case, is going to be come out and is going to be fully segmented. So we took the data, we pretty much did the same kind of thing, thresholding, we augmented because we didn't have enough data into this, and created something like a network like this, the same kind of splitting, 240 patients by 40 by 120. We used somewhere into the vicinity of 2,700 images. And then we tested and see what are our ability to actually segment this and find out what's going on. So when we look at now, instead of like saying whether this now we have quantities to measure, and we are looking at the median volumes and how do they compare with the actual AI. Well, the average user said it's about 13.5. Here, we look at the hemorrhage prediction, it's 13.4. The difference between expert users and the actual AI is 0.1 milliliters. Sorry. So when we look at now other things, this is a dice coefficients, and it kind of like compares structured differences. For example, if I have a cube and I compare with another cube, what is the over predicted by the AI? Are they the same? This is kind of like tells you how much what is the similarity between the two volumes. And when we look again, sensitivity, specificity, negative predictive value, positive predicted value, and the accuracy, this is pretty much perfect. The key is in here is that it takes about 24 milliseconds to calculate the volume. Well, for a human, it can be anywhere to a couple of minutes in order to do it. And here are examples where between successful and good dice coefficients, and here in the you see the comparison between the ground truth in here in red and the prediction, and the actual red curve on the outside is the edge of the ground truth, whatever the expert user has done. We're not always good. Here is a case of a very faint hemorrhage. This is a ground truth, and the AI totally failed to get it. The next thing is large vessel occlusion. Again, this is another thing that is just convenience. And all platforms, Rapid AI, Viz AI, Canon, and probably the other uh, vendors as well. Now they provide this because it's a fairly easy way to detect it. And in this case, the large vessel occlusion application that we are showing you is being trained on 3,000 cases, validated on 450. And what it does, it automatically goes and detects where the occlusion is. And based on this, whether the patient it is a good candidate for mechanical thrombectomy or not. Here is another example. Um, this takes a little bit longer. It takes about 20 seconds and detects occlusions in M1 and M2. And I'm showing in here the Canon version, which has been clear for in July last year. But VisAI and Rapid AI have already platforms, both of them on a mobile units as for this application. Most of the time, the algorithm will not show you um, what is going on where the AI is. It's just going to bring you to the slice where it believes that the large vessel occlusion is occurred and allows the physician to confirm it or not. Here are different examples: right MCA, right ICA occlusion and MCA occlusion for this patients where the LVO has been detected. Others, Rapid AI, actually, instead of having that kind of a box, it gives you an overlay like this, while the Viz AI, again, does the same thing. It brings you to the slice with a maximum intensity projection, showing you most probably the presence um, of the large vessel occlusion. The notification, let's say, if this CTA has been done at a satellite hospital to the point where all the team receives a notification that there is a large vessel occlusion coming, it is about 7.32 minutes. It's slightly longer than the ICH detection. Now, we're moving into a little bit even more complex part, and this is the Alberta Stroke Program early CT score. And again, all these um, uh, platforms provide this. The one from Canon is not submitted yet. And what it does is calculating the stroke to determine eligibility for thrombectomy within the 6-hour window. And again, it just goes, plays automatically these ROIs without any user interface, um, and calculates, shows the Hounsfield units. If it detects hypodensities, automatically is coloring it into that way and presents the, in really fraction of the second, presents the aspect core to the neurology and neurosurgery department. So rapid aspects is shown in here. They have kind of like the same kind of approach into measurement. This is their interface, um, and VZAI the same. I'm going to move to now into the actual CT perfusion and the AI infarct core segmentation, and this is based on dye dilution curve theory. We inject a contrast, and we're going to have this kind of a distribution as the contrast propagates through the through the brain tissue. And what CT perfusion does, it calculates various parameters based on the shape of this curve. So maps like this are generated at every single voxel into the image. Our center is really very thorough about it. We are doing pretty much on every single patient, minus some of the one that have intracranial hemorrhage. So the idea it is to find out into these maps how much tissue is actually dead and it cannot be salvaged, and how much tissue it is actually at risk of being uh, 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 of being infarcted. So there are a lot of advantages in this case for the AI segmentation. When we look at these images, it is in general really difficult to figure out if we put, let's say, a user and ask him, segment to me based on this image, what is a penumbra and what is the infracore? It's going to be kind of difficult. And we can use thresholds. A lot of the companies like Rapid AI, Vital, and Visa AI, they are using different thresholds, different parameters. But if you use those parameters on the same patients, you're going to come up with different numbers. And there is a need to unify this approach. We think that the machine learning techniques might be able to quantify this location better because not only they are going to be trained to, you know, based on the thresholds, it will take into account where it is located. And this is where the AI uh, um, advantage come into place. So, and how do we do this? Well, we go to the ground truth. We take patients that not only have CT perfusion, but they also have 48 hours follow-up DWI, diffusion weighted images. And we create the labels to train the AI based on this data that we know that is ground truth. We take the DWI, we take the infarct levels, we use a threshold on the infarct levels, and now we go back to the CT data and say, I'm going to use this to train for you to segment on the CT perfusion results. Well, we have developed our own software in order to align the MR data with the CT data, which is not quite trivial. In this case, we're using the ventricles. We're using the ventricles into patients to actually, in the bone, obviously, but to actually align the data from the DWI with, um, with the actual CT data. And this, again, it is kind of the, you see the UNet, if you look at it, first is going down, and then we go up convolutions, and we go from something like this to something like that. So again, we take the CT perfusion data. In this case, we can take just, let's say, time to peak or mean transit time and train the AI in order to do this kind of a prediction. And here are the results. We can do just mean transit time. And then not only that, we can take something like this on data and do some mathematical, really standard mathematical procedures or operations to remove things like this, which we know that they cannot be actual strokes. And finally, we're getting the volumes, and here you see the comparison between the um, actual CT perfusion AI predicted volume and the DWI volume. So it works. In most of the times, we get the dice coefficient of 0.87, but not always. In this case, I show in here where we failed. And mostly it's because when we trained the data set, we did not have enough cases for this kind of location of the stroke. The AI will not be able to recognize lesions or other things outside the data set that has been trained for. So if you remember, we were kind of actually, so I apologize for this. We were kind of um, limited in in the number of patients. If we want to be, we use 63 patients and we use the labels in every single slice. So it's 63 times 320. But in order for this to be really, really accurate and so far, probably at least one order of magnitude should be used in this case. So this is showing in here the failure. And then we looked at all parameters. We can train it on every single kind of a data set. We can use CBF, cerebral blood flow, cerebral blood volume, time to peak, delay, mean transit time, in order to train these data sets. And here you see before mathematical standard mathematical operations and after, and they come out to be pretty accurate. When we're looking at other parameters, dice coefficients, sensitivities, specificities, accuracies, and so far, positive predictive values and negative predictive values, they're almost perfect. The only thing, the overlay is not quite good all the time. Well, but we shouldn't be kind of like limited about this values in here. So the best dice coefficient we got is cerebral blood flow in this. Um, what if instead of just using one map, now we're moving and sky is the limit. We can feed into the AI whatever parameters we want. And we really published, the paper came out like 2 days ago. We look at different combinations. We took every single combination that the CT perfusion gives us. And we not use only one map. We are using CBF, CBV, TTP, MTT, and delay. Or we can combine 5x4 or 3x4 and so far and so on. So we do all the combinations. We train an AI for every single one and see how it performs. And we see that some of them are not that accurate, but something like, for example, CBF and CBV or CBF and TTP, I apologize, gives you something better than anything that is on the market out there. And we can take this, and I'm pretty sure that if we will do this with, as I said, maybe one order of magnitudes even of patients, we're going to get these numbers way, way high. So here is an example, and and we look at all possible values when we do these measurements. We look at the median infarct difference. We look at the absolute error. We look at the dice coefficients, positive predictive values, and then we rank with the performance. And in this case, it looks for us that CBF, CBV, and MTT will perform the best if we train an AI with this kind of data. So and that with that in mind, this is the faculty team, and that has been behind all this work. Dr. Siddiqui, it is our director, and Dr. Levy is our chairman. Jason Davies is a neurosurgeon who is also a PhD into data analytics and machine learning. And Dr. Kenneth Snyder is also a neurosurgeon who is a PhD in biomedical applications. We're really, nothing would be possible without this gentleman. All the work that the engineers and the students that are doing, it starts in the surgery room. They are the ones that come up with a problem, and then we're trying to solve that problem. It's not the other way around. We sit up there and try to figure out some sort, and let's see what we can apply this AI. This is the proper way to kind of like do this. And I'm kind of, and the people that have developed all that code that you have seen are right here on this page. In particular, Ryan Ravad, the third in line there, has done all the CT perfusion and CT infarct segmentation, and is involved in all this kind of research. Um, the rest of the team has done a lot of work on the work that I will present in the next two presentations, where we become a little bit more ambitious or riskier and move from just trivial kind of things like not trivial but workflow optimization into things like um, detecting complications or predicting in real time how your neurosurgical procedure goes. And my students over here are also and myself are very interested to talking to any of the neurosurgeons to find out what is your take on actual AI. My email is right here, cnianita@buffalo.edu, and we would really like to talk to you and see what is your take on AI in general, and where you kind of like see uh, this kind of features helping you without kind of taking anything. I mean, the AI will never take anything away from neurosurgeons or neurologists. It's just enhancing their activity. And as I said before, people ask us all sort of things like, what is the likelihood of return to normal? Should I go for these patients to open up or not? Should I go open skull surgery, endovascular surgery? If I go endovascular, what kind of should I do? Should I do a web device, a pipeline to the diversion, or coiling? These are kind of like all. And if I go, for example, with a pipeline, what size should I use? Should I go with a 4.5 millimeter, 4.25, 4.7, 4.75? Oversize, the same size as a vessel, or undersize? So these are things that I think the AI can bring, can solve by, but it requires really a multi-center collaboration, other neurosurgeons. Uh, one center cannot solve any AI kind of a problem. It requires multi-centers, multi-expertise, and large groups. Thank you, guys, and I'm open for questions. Hello?
Mr. Yolita, can I ask a question?
Yes, please go ahead.
So let me introduce myself first. I'm a neurosurgeon. I'm a resident neurosurgeon from Turkey,
Excellent.
and currently we are also working. We have a small research group that we are trying to set up. We're just at the beginning right now, and we have a very small AI prediction algorithm that we have developed on our own. It just right now it just detects if there is any intracranial hemorrhage, nothing more. But we want to advance this, and I'm a neurosurgeon, but I have some computer background, and I made that program, and we want to advance this in a way that we can use in our clinical trials. And I wanted to learn if we can participate as a group, as a center to your projects, and if not, if there are any open source tools that we can utilize for that uh, for our aim.
Yeah, this is
Yes.
exactly the thing I wanted to see happen, Cyprian.
Mm-hmm. We are a research center, and that is craving kind of like collaborations with everyone. With a lot, we cannot this kind of AI things. We cannot, even if we have ideas, we are going to end with those kind of false predictions that I've shown you. If we're using only Canon data, and then somehow Siemens data comes in, it's not going to work properly. We know that that is dependent a lot on the data that you're training for. So yes, we are very much interested in collaborating and working on this project. As far as concerns the code development, I think uh, code development now in the AI has become quite trivial. Um, is there is YouTube tutorials, there is code available everywhere. You just and examples. You can write that kind of a code, but the key, I think, for medical imaging is not necessarily this code. It is what you do to the data before it goes in, and understanding how you can reduce those variables that will throw off your AI. So I think there is where the problem is, or how to fix for different patient variability for artifacts, or how to account for the physiology or the physics of the actual imaging process. So I think as the medical imaging world, it is a little bit different than figure out cats and dogs and pedestrians versus dogs and so far and so on. So I think there is where we can actually collaborate, and where also it is the uniqueness of the problem that we are dealing with. So
Yeah,
I
I
hope
have
I
one.
answered it. Yeah.
Go ahead,
Thank
Mark. Go
thank
ahead,
you.
Marcos.
Yes. Okay, great talk. Really interesting topic. But do you think for brain tumor will be difficult than stroke? What is your opinion about that? Which is the difficulty for brain tumors prediction?
What I've seen so far in terms of tumor, brain tumors, it is to figure out if it is what type of a tumor it is. Things like differentiating between a glioblastoma versus a astrocytoma or something along those lines. Also segmentation to take the volume out and give a measurement, but I have not seen yet things like, for example, to guide a surgery in real time yet. I have not seen yet things like to indicate kind of like how to how to approach this for evacuation and so far. Those kind of things I have not, or how to approach the tumor to spare like sensitive areas around it. So people, neurosurgeons have asked us for this. Another thing is actually I seen the AI, which is out of my area of expertise, in actually looking into the genomics of it and determine whether it's going to be responsive to a certain drug and so. So I've seen those applications. As far as concerned as I kind of like focus on endovascular applications and stroke, and eventually we're going to move towards also some brain tumors. But the order on which this team is going to go about is endovascular applications, a lot of them, and our team is really keen on spine and cervical intervention in particular. Other than that, it's as I said, as I showed you before, we're a team of couple of people, a dozen people. We cannot solve all the problems, but I think on the even on the tumors, there are a lot of applications, and we will be willing to collaborate with others uh, if there is a need.
Is there a place where you can look at all the research that other centers have done besides Buffalo? Like, what are the big research centers, would you say, in this area of artificial intelligence and neurosurgery?
John Hopkins, I'm talking here like neurosurgery applications. And so John Hopkins, it is huge. There is Jeff Sewardson in there with his team. There is the Duke folks are also very much involved into this. Mayo Clinic, they have a lot of applications, and so UCSF also a big center and a lot of expertise right there. Um, one of the issues that stops us from collaborating all these teams is data sharing and the RB's problems.
Okay.
So we're looking into ways to go to actually do machine learning without actually having the data downloaded onto our one center or so. What is called as federative learning. We're very interested into that. The training actually takes kind of place into the cloud, and we are using the data and the labels at that institution center without ever needing to take it out. IRBs as of now, and patient information sharing. It is, I would say, the second most difficult or the second blockage into this research. First being you need expert level expert users to label the data, and there's not too many neurosurgeons in the world or people with a neurosurgery expertise to do that, and their time is very valuable.
Right. Of course. Okay. More questions or comments from the panelists? The floor is open.
If you have questions and if you'd like to talk to my team in a different context and so far, we're all willing and open to have Zoom meetings and discuss with you. We're stuck in our labs and remote working and so we're more than
Okay.
willing to meet with you.
Okay, you want me to put contact info in the chat?
Yes,
Yeah.
I'll put
Yeah,
my email in here.
Yeah, and I'll just copy and paste it. You just emailed it to me?
Not yet. Unfortunately, I did it to only one person. Let's see. There it is. So,
Or just show it in the screen, or?
it's in the chat.
Oh, okay.
Is it?
Okay. Oh, there you go. Does everyone get that? You see his email? Okay, it'll also be posted on the Neurosurgical TV page. I'll make sure I save that. Let me save that email.
So next one where I'm going to present, it's going to be a little bit shorter, but I'm going to show you how we can use some of these AIs in order to detect complications in real time during the procedure, to endovascular procedures next week with a shorter version of this.
Okay, very good. Okay, any closing comments or questions, or just someone that wants to say hi? But you know, Cyprian, this technology is kind of new as far as interacting over something like this. And so the audience is probably like me. They don't know much about it yet, but hopefully we'll learn. Hello, Danu, any comments? Abu Bakr, any comments or questions? Or just to say hello? That's okay. Okay, I guess everyone's shy today. Okay, Cyprian, thank you very much. We'll have this edited, sent to you. Thanks for your time. Thanks for all the research. And we look forward to next week.
Okay, have a good one.
Thank you. Bye-bye.